We have our vision of really having Kansas City delivering the highest value, most equitable healthcare in our nation. And our mission is really to catalyze and facilitate these multi-stakeholder collaborations so that we can improve the quality and value of healthcare. And we're really brought together and supported by a number of partners, including BioNexus KC, UMKC, as well as Mizzou's, University of Missouri's NextGen Precision Health Institute, and KU Frontiers Clinical and Translational Science Institute. And in order to get all these multiple stakeholders together, improve quality of value of healthcare, what we're really trying to do is, we know the kind of the IOM and National Academies of Medicine and the whole learning healthcare system, right? Where you take learnings and you use those learnings to change kind of the clinical practice you deliver. But what we're really trying to do is move a lot bigger from, one clinic or one hospital or one care setting into really creating a community and a learning health community in which different hospitals and providers, as well as other stakeholders, can kind of share and discuss together, and we can all get better together to really maximize population health outcomes. And within the QVIC, we have really kind of three main strategies by which we use to reach our goals and our mission. And they all really work synergistically together. So the first of our strategies really is this regional quality improvement. And what we have been doing here across the Kansas City metropolitan region is really engaging with a number of different clinical sites, hospitals, healthcare systems, and bringing evidence-based programs or projects to the hospitals, and then helping them to both implement and then measure the outcomes, whether or not they were successful in achieving their goals. And so these regional quality improvements definitely are a big bulk of the work that we do in the QVIC, and a map on the left there is of Kansas City for any of you not familiar with Kansas City, and in the red is our participating hospitals on our opioid management project, and on the right is our transitions of care for heart failure project in blue. And then in order to actually, as many of you know, in order to actually implement some change into practice or into communities, you really have to lean on the lessons of implementation science. And so what we recognized and developed was that need, right? And so we developed a training program called TIARA, or Training and Implementation Actionable Research Approaches. And we developed this training so that we could better equip, healthcare providers, researchers, et cetera, on how to actually take something evidence-based, understand barriers, overcome barriers, implementing strategies to put them into care, and then how to measure those. And so, we've really operationalized our training, and we're continuing to grow that as well. So stay tuned to reach out if you have more questions about that. And then we also, in our third bucket, kind of focus on dissemination and engagement. And our primary activity there is, kind of why everyone is here today, which is this is our monthly forum, the KCQVIC forum, where we bring multiple stakeholders together to talk about different healthcare topics that are a priority for our region and largely also for our nation, and to talk about these, but to hear from different perspectives and kind of have a community conversation about ways we can improve our community. And with the QVIC forums, here's just kind of I guess, the schedule for 2022. So if you want to see the upcoming dates and topics as well. And then I always raise this as well, but if you see any of these topics where you just know someone who's doing really phenomenal work, a community-based organization, a payer, a provider, a researcher, a patient, an advocacy group, policy perspective, if you know any great speakers, please do send them our way. And so thank you, Pat McDonald. I have your email up here, which I'm sure you so appreciate. So everyone say hi to Pat, and then please send her any recommendations you may have for any speakers on any of these topics. And we look forward to you attending those. And then, that kind of brings us to today, our QVIC forum, on behavioral health, or healthcare's third rail. And so I just wanted to bring up, I'm sure many of you already know this, but the whole third rail definition, or I just wanted to bring up what that is, which is, really the third rail is kind of that metal rail through which electric current is passed, right? And this is, given to a motor on a train, right? And it's also known as the live rail, the electric rail, the conductor rail. And, these used to be above ground, which you sometimes see. They're also right here as the third rail on the ground level. But really the whole point is this is the topic, or this is something that no one wants to touch, right? And so, the reason we're calling, behavioral health healthcare's third rail is we know this is a very hard healthcare topic for many reasons, right? This is there's still, unfortunately, a lot of stigma and discrimination surrounding behavioral health. We also know that there's still, despite a lot of policy level changes, a lack of parity between physical and mental health, both in terms of detection, in terms of treatment, in terms of still related to that stigma and discrimination. And we also know that there's a lot of difficulty with treatment, either identifying it or having adherence to treatment. There's just a lot of difficulties that we're facing. And so we know that behavioral health is incredibly important. It's incredibly prevalent. It's a huge problem in our nation. And I would say that COVID's really made it a lot worse as well. But I'm really, really excited to have this forum here today so we can kind of talk through this together. And then also in terms of timing, it's really relevant since, May is the Mental Health Awareness Month for our nation. And so it's just great that we're calling more attention to this right now. And then I guess with that, you are done hearing me speak, and I will turn it over to our first esteemed speaker, who is Dr. Kenneth Minkoff, who's a partner with Zia Partners and a clinical assistant professor at Harvard Medical School, and the co-author of the Behavioral Health Asset Mapping. So we are very excited to hear from you, Dr. Minkoff, and the floor is yours.
Well, thank you very much, Stacy. I appreciate that. And I was frankly puzzled by your definition of third rail, because I think third rail behavioral health is really an exciting and stimulating, fun thing to talk about. So all that current in the third rail just gets me juiced. And hopefully y'all can join in the excitement as we dig into this. Because as a cutting edge issue, which is actually one of the few places where there's bipartisan agreement of the importance of action, both at the federal and the state level in Missouri, this is a really cool topic right now. So there's an awful lot to cover here, but I'm going to focus on one particular project that I was the lead on. And I'm not a researcher, actually. I'm an implementer. So I live in the world of providing consultation to large systems using a framework of implementation and science and quality improvement to improve, not to move past the idea of implementing individual projects or programs, to how to transform systems to better meet the needs of the population. So it feels a little bit like I'm a kindred spirit to what you guys are trying to do. And this project was lined up with that. And there's a lot to this project, much more than can be covered in 10 minutes. But I'm going to try to hit some high points for you guys and to particularly stimulate some thinking about the parts of what we did that are most relevant for Kansas City and Jackson County. So this was a project called Behavioral Health System Asset Mapping that was jointly funded by the two health foundations that cover Missouri. Missouri Foundation for Health, which covers almost all the state, and Health Forward, which covers the region around Jackson County. There are several counties that are part of the Health Forward region. And the goal was to provide for us to work throughout the state to identify those areas of strength and capacity for the population of Missouri as a whole, not just the public population, not just the indigent population, but all Missourians, and to identify the strengths and then the improvement opportunities, both at the state level and then use what we call deep dives into a selection of regional systems to to indicate areas of improvement both in those regions and also to inform the larger project. There was a team of consultants, and you see all our logos and all of that stuff. Now, this project began in December of 2019, and we started when there wasn't a pandemic, and we wound up doing almost everything virtually. And the final products were developed and completed and submitted last July. There's an extensive report that we submitted for the whole state to Missouri Foundation for Health, which they have and they're using in their advocacy and strategic implementation. And there was also a specific Jackson County focused report that we provided to Health Forward, which they have, and they're using in whatever way they feel is best. And I'm going to focus, they gave me permission to share this, so that's what we're going to be focusing on. So the idea of the way we frame this is to compare Missouri's delivery system to a model that our consulting team has developed for an ideal, quote unquote, community behavioral health system for an entire population. And as I said, we were looking at how this laid out in terms of state policy and implementation activities at the highest level, but also then doing deeper dives into 12 communities all over the state, urban and rural, to see how this played out, and then to identify potential opportunities for state and local behavioral health stakeholders to convene, to work collaboratively, to establish partnerships that enhance reach and capacity to change by better leveraging existing resources through a systemic lens in terms of shared quality improvement, or if you want, collective impact, to improve the overall functioning of the system for the population. Now, this lovely diagram is our vision of an ideal system. We actually came up with a slightly more elegant diagram during the course of the project, but this is the one that we used during the course of the project. And so let me just explain the major components of this. First of all, the idea is that behavioral health systems need to be organized at the community level. They can't just be figured out through the State Department, and the State Department only has a subset of all the funding and the scope that's needed. So one of the things you might ask yourself is who's responsible for designing and implementing the behavioral health system for the population of Jackson County, Missouri. And I know you guys like to cross boundaries between Kansas and Missouri, but just focusing on one component, what's the Kansas side, what's the Missouri side, who's responsible for that? And what we found, as you know, is that there is no locus of responsibility at the community level anywhere in Missouri that's really responsible for local design. So folks have to bring themselves together to figure out how to implement all these various things in order to have the most likelihood of success. The starting place is that the success of the system is built around people having successful lives in the community, which involve interventions to create healthy communities that don't, are healing from trauma, not traumatizing, and help people build healthy lives, avoid adverse experiences, as well as specific prevention activities, both the extent to which no trauma produces positive results, as well as targeted prevention like suicide prevention and so forth, as well as, creating recovery support for people with more serious illnesses, integration into healthcare, both primary care and general healthcare, so that as much as possible, behavioral health interventions are identified and intervened in an integrated way within the healthcare system. And then for those folks who need more targeted or more intensive, there's a specialty system for people with SUD needs, people with mental health needs. Wherever people show up, they may have co-occurring the other kind of issue, so everything needs to be integrated. And there's outpatient rehabilitative services, more intensive services. And then there's a crisis continuum, which is the safety net that includes a whole array of emergency diversion services, which is kind of a big deal right now in the country. And then a system of recovery supports, including peer support, supported housing, supported employment, that help people who have serious and long-term persistent conditions to make the transition from and with specialty care back to having healthy lives in the community. So that's our one slide document of a healthy system. And so here are all the things that I just described. And then part of what we looked at in every community was not only the identified services, but how do they overlap with other components of service like housing, justice, intellectual developmental disability services, child protective services, adult protective services, schools, and the like. Now, when we did this deep dive, we did this in 12 different communities, Health Forward had some unique requests. So Health Forward pulled together an array of partner funders, and you guys are, United Way, the Jackson County Mental Health Fund, there are a number of them, Children's Fund, and worked with us to say, what do you want to focus on in our deep dive in Jackson County? And what we agreed on is we would cover the bases, but the most important thing was to look deeply at issues related to disparity, equity, and inclusion in the population, and to look particularly at some of the smaller providers that were working with unique populations, and to see what could be done to help and support and engage them. So we did about 60 interviews, and out of that work, we identified some key, we did a whole long report, which I can't possibly go into all of the details, but we identified some particular prioritized recommendations, and they're all about how to bring together a collaboration in Jackson County in particular that can leverage the idea of using big scale quality improvement to improve the behavioral health of the population. And there's both structure and process and particular prioritized activities that we recommended. So one of those is to focus on developing a regional behavioral health collaboration on 2 levels. One of those levels is there are multiple funders and they're all doing similar things, but they cooperate, but they're not a fully realized funder collaborative that works together to do coordinated, systemic, ongoing strategic quality improvement. And what we found is that many of the funders would love to have such a thing. And we recommended that everybody take steps to sit together as funders and think about how to pull that off. And then one of the things we recommended that they do as a first step is to create a formal behavioral health system collaborative partnership akin to one that operates and is quite successful in the greater St. Louis region, which does the kind of projects, some of the projects that you've been describing, but in a systematic way, called the Greater St. Louis Behavioral Health Network. And then within that structure, which would meet regularly as a team, there's the capacity to engage the DMH funded components of the system and the CCBHCs with health systems, bring the smaller unique community-based providers to the table, bring other system representatives, and build an ongoing collaboration to move Kansas City toward the ideal behavioral health system. Now, there are 2 areas of priority activity that we recommended. And the first one was crisis system development. I chaired a report called The Roadmap to the Ideal Crisis System, produced by the Group for the Advancement of Psychiatry and published by the National Council in 2021. It's a 200-page map of how to move toward communities developing the kind of behavioral health crisis continuum that begins to resemble what we've come used to in EMS. And this is an immediate need because of the implementation of the 988 call line nationally starting in July. And then it becomes, what do we need to do to pull ourselves together? And right now, the system, there are crisis services in Jackson County, but there's no system. It's pocketed. The capacity is way too small for the volume of need. And there needs to be a collaborative process to begin to work together to develop a strategic plan and implementation of filling in those gaps according to national best practice guidelines. The final high-level recommendation, which is more aspirational, is, as you guys probably know, there's a lot of different collaborative activities in the Kansas City region for creating trauma-informed, violence-free, healthy communities. And we label this healthy children, healthy families, healthy schools. And what we found in our analysis is that each of these was doing really cool stuff. And all of the things they were doing were lined up from a value perspective, but there were real opportunities to bring things together that were underdeveloped, if you will. So there's Children's Mercy has an at-risk Medicaid contract that leverages a whole bunch of resources over there, and the schools are doing something else over there, and there's different initiatives and in the system that are doing other things. And we recommended that under this umbrella of this collaboration, that one of the strategic improvement activities would be to bring all of these things together and really focus on how to, from the neighborhood level on up, how to bring everything together, health, human service, behavioral health, to really improve the functioning and the outcomes of the communities, and use the availability of all different kinds of funding, including the at-risk Medicaid funding, to try to achieve that. So this is a big deal. Mostly I want to flag for you what the vision is, and also the awareness that, Health Forward has all this detailed information that we produced that may be helpful for you guys in various projects that you're going to undertake. So thank you, and back to somebody to do something next.
Thank you so much, Dr. Minkoff. That was great. Great. So we'll turn it next to hear from a policy perspective. We'll be hearing from Valerie Hoon, who's the director and within the Missouri Department of Mental Health.
All right. Thank you. And thank you, Dr. Minkoff, because I agree with everything you were saying. And I have a lot of those as part of advancing the continuum of care and what we're getting ready to show you. So I'm going to try to, went too far. Before we get started, I do want to introduce the Department of Mental Health, DMH's Western team. I do have them on the call. I think part of collaboration is important to know who the best person to collaborate with. And we've got a great team on the ground in Kansas City. On the call today for us is Denise Norberry. She's our Regional Executive Officer for our Division of Behavioral Health. And under Denise, she's got Janet Munsterman, who is our Chief Adult Community Operations Director. Mariah Taylor, who's Chief of Children's Community Operations, and we will soon have a new member, our Chief of Substance Use Disorders, and that's Lauren Quint. We also have Megan Radel. She is our Chief Operating Officer for the Center of Behavioral Medicine. And then for our Division of Developmental Disabilities, we've got Clay Stearns, who's our Assistant Director for the Western Region, and Lisa Tracy, who operates our Kansas City Regional Office. And if there's others on the call that I've missed from the DMH Western team, put your name in the chat. Everybody else, feel free to put your email in the chat and introduce yourselves. In the meantime, I do appreciate Dr. Minkoff pointing out that it is not the State Department's role. We have a role in mental health across the state, but there's also a large importance put on what happens in local communities. And the St. Louis Behavioral Health Network is a great example of how you build that collaboration, and then how the state agency can use that collaboration to even continue to push innovation. We're going to talk about what DMH does, some current DMH services, and evolving strategies for the continuum of care. So the role of DMH, we are a provider of mental health services in the state of Missouri. That's not the case for all state agencies.
Valerie,
yes.
May I jump in and interrupt? I believe we're still looking at Ken's screen, and if you're trying to show your screen, we're not seeing it.
Okay, it says you are screen sharing.
Now it says it. Okay, we were still in Ken's screen.
Right.
Were there slides before this that you think you need to go back to?
So you can see it now? Okay, I
see it
can.
now.
Okay. No, I think we're good. We can go from here.
Okay, thanks. Sorry to interrupt.
Oh, no problem. So DMH serves as a provider. We serve as we're a provider. We operate state psychiatric hospitals. We operate state rehabilitation centers for individuals with developmental disabilities. We also offer community-based programs, both for individuals that are leaving our psychiatric hospitals and our rehabilitation centers. And then on the developmental disability side, we do about 1/3 of the case management in the state of Missouri. We're also a huge funder of services. The Department of Mental Health just recently got a $3 billion, that's the billion-dollar budget passed. The bulk of those services are paid through Medicaid. We have block grant funding, complements of SAMHSA and the federal psychiatric comprehensive mental health block grants. We also have some limited general revenue only funding that we can use for non-Medicaid type services or individuals who aren't Medicaid funded. A lot of the individuals are supported through autism supports, and then non-Medicaid type services are going to be housing type services. We are a program developer. We've done a lot of program development over the years. We were one of the first states to implement a health home program, and we started that in 2011. We're fortunate that both our CCBHOs, Certified Community Behavioral Health Organizations, our community mental health centers, and our FQHC's primary care health home are operating in Missouri for our Medicaid population. So we do work to try to integrate both the physical and the mental health in those health home programs, and have seen some really impressive outcomes. That program is a Medicaid enrollment, like I said earlier. We are one of the few states in the country that started with transitioning from a community mental health center model to a certified community behavioral health organization model. Key component of that was changing how we pay for services. And so now instead of paying 15-minute units, we now pay a rate for services, a prospective payment rate. And then we were also, with the National Behavioral Health Council, one of the program developers for the Mental Health First Aid Program, which is a national program. Also, teen mental health first aid is included in that. And we've been partnering with DESE over the last year to work to get that mental health first aid program and the teen mental health first aid program in schools across the state. We're a program implementer. So Medicaid assisted treatment we began doing in 2006. The state of Missouri requires all SUD providers to provide medication assisted treatment. We also work with our Department of Corrections on medication assisted treatment and are looking at some new programs in that area in light of opioid use disorder funding coming to the state. We do recovery supports, we do housing, we support employment. We've got some housing implementers that we put into place across the state over the last year, and employment will always be a priority of the Department of Mental Health. Also, crisis services, was happy to see that on Dr. Minkoff's slides. I'm going to go into that a little bit more in detail in a little bit. And another thing we've done is the Emergency Room Enhancement Project, where we try to increase behavioral health access for those high utilizers of emergency room. And in 2021, we had over 24,000 emergency room users referred to this program. About 15,000 of those were eligible, and we were able to engage over 13,000 of those individuals at the ER level to get them out of the ER and into the right programs and supports. And then finally, we are a program evaluator. We'll be moving more to value-based payment. This is both on the developmental disability side, but also for our certified community behavioral health organizations. And that, when you pay for value, you become a program evaluator. You're looking at data. You are paying. You're paying for quality. We do a lot with peer supports, and then we continue to advance and evaluate how we can better with integrated treatment. I'm going to try to. So now that you can see my slides, there it went. I couldn't advance them anymore. These are the two major program divisions for Missouri's Department of Mental Health. There's our Division of Behavioral Health. Across the state, we fund mental health treatment for over 42,000 Missourians, substance use disorder treatment for over 17,000 Missourians. We support opioid risk mitigation, and we also operate state psychiatric hospitals for forensic patients, like I said before. Our Division of Developmental Disabilities funds Medicaid home and community-based services for almost 16,000 Missourians. We also operate facilities and the community for over 450 individuals, and we fund and provide case management to 42,000 individuals with developmental disabilities. Also, we've got autism centers and programming for individuals with autism who are not Medicaid eligible. And it's not switching again. I'll keep talking. The next slide would show you what the different type in our division of behavioral health, some of our different types of services and programs. And these are, there it went, these are our current psychiatric programs. These are advancing. We were the benefactor of a lot of funding and a lot of changes, especially in the crisis world. So while this shows access crisis intervention, when we talk about the continuum of care, we're going to talk a little bit more about what that is in the future. We also do assertive community treatment. We have a lot of outpatient community-based services that we fund. There's targeted case management on this side, day treatment, residential, inpatient diversion. We talked a little bit about our ERE program, respite, treatment family homes, community psychiatric rehabilitation and recovery supports. And then when you look at our substance use side, we have our C-STAR programs for women and children, C-STAR for adolescents, C-STAR opioid. We do C-STAR for the general population. Then we have primary recovery supports, early intervention, and our SATOP program. But when you're looking at public policy, what does that mean? What's the Department of Mental Health looking at and focusing on for the future? What are we talking to legislators about? What are we working on new budget items for? So I look at it in two ways. I look at the continuum of care through the lifespan, and I look at continuum of care through services. So when we look at the lifespan, some of the things we're looking at on the early childhood side are support for families. How do we help families early on? And I can speak more to it on the autism side, but what can we put in place early on before a family gets into upheaval, or I don't even want to say crisis, because I don't want families to have to get to crisis. So we'll continue to look at support for families. Support for providers. There's our Child Psychiatry Access Project, which pediatricians across the state have access to, that we've partnered with the University of Missouri. And so what we know is a lot of times primary care pediatricians are the first point of contact for somebody who needs behavioral health services. We also know that we have a limited workforce across the state. And so how do we build in at all different levels of the lifespan access to care and in the lowest level of care we can as early as possible. And then we also want to look at training for providers. And again, for early childhood, we're looking at pediatricians, we're looking at childcare providers. So we are, it's important that anybody who's around children early childhood understands, identifies behavioral health as a priority and helps folks get connected where they need to get connected. So when you look at continuum of care in the lifespan, we also look at school age services. And I did mention earlier, we are working with DESE this year was announced the teen mental health first aid program and mental health first aid program available to all the schools. We also just recently launched a trauma-informed initiative that anybody in the state can take advantage of, but it helps you gain a basic trauma level training. Then we are very concerned about transition to adulthood. And we have transition age youth programs so that we start talking about transition early. We want to make sure that you have access to employment, that you keep your services that you need, and that you have housing, all the things you need to transition to adulthood. We always look at young adult first episode psychosis, that we focus on adult, and now more than ever, and probably where I would say we're the weakest and we do need to spend some time, and this is focusing on aging. Because not only are the people that we support with behavioral health aging, so are their caregivers and their family members. And we've got to make sure that that continuum exists as their support system changes over the years. So those are really important when you look at the lifespan. When you look at the continuum of care of services, we want to build services to avoid intensive crisis that result in jail or long-term hospitalization. So we have started the Community Behavioral Health Liaison Program over the last few years. The crisis centers have been put into place, and there are crisis centers. I'm going to flip screens on me real quick. In the Kansas City area, we have the Kansas City Assessment and Triage Center. There's a behavioral health urgent care center in Raytown, and there is another behavioral health crisis center in development that should be up and running in October of 2022. Those behavioral crisis centers are very important because there's also the access crisis intervention hotlines that are operated by ComCare in the Kansas City area. As of July 1st, that will turn into 988. That is a talk, chat, and text function, and ComCare will be taking those calls. But you can't just take the calls, you have to have a continuum of crisis care as well. And so 988 gives us someone to talk to. but then you have to have somebody to respond. And so we are working on building mobile crisis teams so that they can respond. We do have those operational across the state currently. We know that those are going to have to be enhanced. And so Rediscover, SWOPE, Tri-County, and Truman Medical Behavioral Health all are currently developing mobile crisis response teams. So that is going to be a key component to success in this 988 crisis continuum. Then the last thing is that you're going to need somewhere to go, and that's what those behavioral crisis centers are. Currently across the state, there are 13 operational, and like I said, those are the 3 I just discussed in Jackson County. We also need to develop a workforce at all levels, and I really probably should have just put workforce on one slide and put it out there, because that is probably the right now, on my side, public policy, biggest thing that's preventing anything from happening. We are in a major workforce crisis, and that's at all levels. We need more peers to help deliver service. We need more direct support professionals, and we need more clinicians. We are not good in any of those areas. In fact, our behavioral crisis center should have been up and running before even the end of this fiscal year, and we're looking at October of 2022 before those are able to fully operate. So like I said, right now you could wipe all, I don't want to wipe all of this off because we have to talk about all of it, but development of workforce for mental health at all levels is probably the #1 public health, behavioral health issue that we are facing. And we've got to meet people early. We've got to get them interested in early, junior high and high school. We've got to make it easy for them to go to school. We've got to make it easy for them to work. We've got to show them the value in these professions. So I can talk about that all day. The other ones that we can talk about real quickly, we want to expand medication-assisted treatment for people with SUD across all of the Department of Mental Health. We want to continue supporting movement to trauma-informed system of care. I'm really excited about that, the 2-year initiative we have out there just for basic training around trauma-informed. I think that's important. We want to support innovation to deliver services in the least restrictive setting. And we want to use technology to better inform integration of treatment. I am a huge fan of technology, and that's a whole nother day of conversation. Thank you for your time, and I am done. There's my email address, and I'm sure the team has made themselves known in the chat. Thank you.
Thank you so much, Valerie. That was a wealth of information, and so happy to hear everything that your organization is doing for Missouri. So thank you. And now we turn it to Carrie Bruffett, who is the brand new President and CEO of the Kansas Health Institute. She'll be speaking from a Kansas nonprofit organization policy perspective on a public policy development process for behavioral health modernization and reform.
Hi there. Thank you. Good afternoon. Can you all hear me? Okay, good. You know, you're going to see some familiar themes on my slides as well. I think you could probably say this about a lot of states. The issues that Valerie identified that Missouri is working on, even though there's different approaches and Missouri's ahead of the game, like with the CCBHC model, and Kansas is really following. There's a lot of similar themes, but one thing that really rung true was workforce. I'm here at a conference for a network of public health institutes, and it's an issue in public health, it's an issue of behavioral health, it's an issue across healthcare. So I think that was really important and important to reiterate, because I just have like one slide about it in here, but I agree with Valerie, that could be the first one in every one. So thank you. I'm Carrie Bruffett. I'm with Kansas Health Institutes. Going to go through and talk a little bit about a process in Kansas, and some of you may have heard about it over the last few years, for developing recommendations and priorities for this at the state legislative level, but in cooperation with the executive and now the judicial branch as well, for policy interventions to try to address some of the issues that Valerie identified, and some other ones that are Kansas specific as well. So KHI, if you don't know who we are a nonprofit, nonpartisan educational organization. We're based in Topeka. We've been around since 1995, and we're right across from the state capitol, although I'm in New Orleans today and working from home some other days of the week as well. But we are committed to having meaningful conversations around tough topics related to health, tough and important topics. So I agree with Dr. Minkoff that the third rail is exciting too. So And behavioral health is one of those, absolutely. So PHI for the last several years has been involved in a number of policy recommendation development processes where we have supported with some evidence-based practices around process facilitation, and then also just some research support for some of the policy recommendations. But all of these recommendations have been developed by groups of stakeholders, including providers, including people with lived experience in behavioral health, with the behavioral health system, as well as policymakers and advocates and associations as well. In the last couple years, in 2020 and then in 2021, the state legislature established a special committee, and they had two different ones. And in 2020 and 2021, the Special Committee on Mental Health Modernization and Reform, it included legislative members, chaired by legislature, vice chaired by legislators, but also had non-legislative members as well. And then it had a cohort of working groups, and working group members included legislators, but also included other folks who weren't necessarily the roundtable participants. Roundtable participants came from state agencies, came from associations, did have people with some lived experience as well. But then the working groups were even more populated by people with those experiences. In the first year, there were, in 2020, and this was an interim committee, so it met, in 2020, it met from August to December, and in 2021, we'll see here in a second, met from September to December, establishing 3 working groups and a telehealth subgroup. So they were focusing on issues, and we'll talk about sort of the groupings of issues in a minute. Finance and sustainability, policy and treatment, and system capacity and transformation. And then there was like a telehealth subject that hadn't been assigned, but each of the 3 groups was talking about telehealth. So they formed a subgroup in that first year. First year, there were a number of recommendations. We'll sort of talk about the format for them. But then there were some of those high priority recommendations were enacted. Those that required legislative action were enacted. So the legislature came back and said, gosh, let's do it again. We want to kind of go through and say what hadn't yet been completed, what should we continue to prioritize? Maybe there's something new. Now that we've learned even more during the pandemic, what we do to add. So year 2 looks pretty similar. Again, there was a special committee with roundtable participants and legislative members, many of the same people, but they actually added more representation from the judicial branch, for example. So they had some judges that were represented on the roundtable as well. And then the working groups are a little bit different. Telehealth kind of got elevated to its own special working group, but we also had the services workforce and system capacity and transformation. All the topics still sort of survive from year to year. So that's the framework for what the conversations look like. Each of the working groups in this second year in 2021 met either 4 or 5 times each. So they would go through the process. The first year was looking at previous recommendations that other task forces and working groups and committees and advisory groups had put forward regarding behavioral health in Kansas over the last 10 years, but particularly the 5 years leading up to that. Prioritizing, focusing on those and refining those recommendations and saying, hey, here's something you can actually do. And legislature, this requires an action by the legislature to do, or we're going to recommend the agency do such and such, or maybe this is something for another branch of government. And there are a couple of those kind of recommendations we'll talk about in a minute. So, and then the second year, they again went back and looked at what they did the first year and said, hey, what do we need to do? They came up with 10 new recommendations, but revised 20 of the previous recommendations as well. So there were 8 recommendations that had been completed, and one of those was that for Kansas to create a model that is based upon and is building upon the Certified Community Behavioral Health Center clinic model. And we'll talk about that in a minute, about how that's going in Kansas as well. So they wanted to say, what's the next thing we want to do as well? And so hopefully this can help outline to you the kind of things that are really important to stakeholders in Kansas. Again, they're going to look very familiar, and maybe where there's some potential research opportunities as well. I mean, some of these areas, I know the next presenter is talking about outcomes, and I can't tell you how often that comes up as a key issue in each of the discussions around all these policy issues is, well, that's great, we want to do this, but how can we tell that what we're doing makes a difference? So that continues to be a huge need and a demand of policymakers to say, we really want to understand what we're investing in and not just putting financial resources in, but investing time and policy strategy. And is it working? Is it working? Not just did it get implemented, but is it moving the needle? And which needle are we wanting to move? So I think that's a really important conversation. So I'm looking forward to the next presentation too. Again, I already kind of went over this slide, but the first year was establishing the strategic framework. And in the second year in 2021 was to update it. So there were completed recommendations, revisions, and new recommendations. I have a link to the report and we'll share around the copy of the slides, but there's two different reports. And if you really want to dig into it, there's also the links actually take you to the full report. So it also has all the legislative report wrapped around it, like the legislative committees saying, here's when we met and here's who testified and so on. But then there's also just the meat of the recommendations. That's the body of the report. There were, for all the priority items that were identified by these working groups and then ratified by the special committee, there were some that were identified for immediate action. And so the thought was that these could be completed within the next 2 years. And then some were, which are of strategic importance, which doesn't mean lower priority. It means you need to start now, but we know it's going to take longer than 2 years. So some of the sort of long-term things that Valerie and even Dr. Minkoff talked about are not going to get done in 2 years. We're talking about really looking at systems and digging into issues effectively. And then they also each year had talked about the higher priority discussion item around Medicaid expansion, which is important to a lot of the participants, but there are certainly different perspectives and opinions from the legislators that are represented on the special committee. So these topic areas, and I won't go through all of them because, but we kind of use similar layout, Valerie, and our slide templates are pretty similar, but the topic areas and the recommendations within each were workforce. Yes, number one, it was one, although workforce 1.1, 1.2, 1.3, several recommendations. We'll talk about a couple. Funding and accessibility, community engagement, prevention and education, treatment and recovery, special populations, although people decided they did not like that name for the group, but that was children, vulnerable populations and others. So that's a couple of those recommendations we'll talk about as well. Data systems, the legal system. I pulled out some examples here because sometimes folks we're not thinking what's the connection here with the legal system. So example, there's discussion around expansion of specialty courts, and Kansas has and many other states have experienced this as well, delays in competency evaluations or competency restoration services for people to be able to stand trial. So there's a real practical as well as purposeful need there. And then system transformation, which is about integrating primary medical and behavioral health care and implementing models like the CCBHC. And then telehealth. Again, telehealth took its own focus this year. So I'm just going to give you a sample of the recommendations, because if you look at, there's a nice little table that has a lot of recommendations. If you look at all of them, you count them all up, it's like, oh my gosh, there's 50. And there are about 50. There's some of those have been completed. I think there's 56, but 8 of them were completely finished before. And then some had been revised, were pretty much close to finished, had been, for example, the CCBHC model is still in implementation, but the legislative action had taken effect. So it's still live as an in-process recommendation. Some of the new or revised recommendations, or significantly revised recommendations that I thought might be of interest to you all, thinking about potential policy activities or research activities, and or just some recent current events that are happening as well. One was to extend Medicaid postpartum coverage. Kansas has had 60 days postpartum Medicaid coverage for pregnant women, and with now there's been different ways to do it in the past, but now with a particular state plan amendment option to be able to extend to a full year. There was discussion, and the recommendation technically was to ask the CanCare Oversight Committee to review and recommend postpartum coverage extension, but that was discussed extensively. Exploring regional specialty courts, the special committee and working groups heard from some of the judicial districts who've had a lot of success with different kinds of specialty courts, whether those are drug courts or veterans courts or mental health courts. But they know there's some capacity issues in some of the judicial districts. So an idea, and the judges were kind of like, well, kind of like it, but then we're not sure it's completely going to work. Was to think about, could they be regionalized sort of beyond the judicial district, or is there some other model, some kind of venue transfer model that could work to be able to open up access to those really successful specialty courts throughout the state. Developing or expanding the mobile competency evaluation and restoration services was recommended as a priority, and actually we'll talk about it in a minute, was something that's in the current budget bill that's been passed. Expanding something that has been around for a few years in Kansas, the Mental Health Intervention Team program, which is a program that provides grants for school districts to hire school liaisons and then enter into MOUs or other sort of agreements with mental health providers, whether those are community mental health centers or other health providers, to provide clinical therapists and case managers in the schools. And so they were looking to expand those programs. Are currently, I think there's 56 school districts and more than 200 school buildings in Kansas that have access to this program. Creating a workforce investment plan. There are a couple of recommendations about workforce. One, to do a study, kind of like the asset mapping, but also what are the needs, the needs assessment for workforce. In Kansas, they heard from a Nebraska model, the Beacon, can't remember the entire acronym, behavioral health, something of Nebraska. And they're the great work they've done up there with really a rigorous and systematic approach to workforce development in the behavioral health space. So they're interested in that, but they also wanted to look at like the investment, workforce investment plan as well to follow up with that. Kansas has been looking for a few years at trying to expand a regional model for inpatient mental health capacity. And Valerie talked about mobile crisis units as well. That's tied also in Kansas to funding the suicide prevention lifeline. It's not so much really funding answering the phones, that's part of it. It's more what happens after you answer the phone, and people actually need services. So that was another high priority recommendation. So you can see and suicide and concern about youth suicide rates, as well as suicide rates and sort of impact in rural and frontier areas of the state really were important to this working group and to the special committee and the working groups this year. So there were other recommendations related to suicide prevention as well, but this was sort of the highlight one, I suppose. So a couple updates. So what's happened, kind of give you an update on where things stand so that report was completed in December. The special committee made some modifications to some of the language, but adopted all of the recommendations. And then some of those have actually gone forward, and again, during this legislative session have moved to the next stage. So in 2021 is when legislation passed to implement a timeline for CCBHC implementation in Kansas. So the schedule, and I'm not sure if it's all completely up to date, but the schedule is initially to have some, and there are a couple that are already CCBHC had gone through the federal process, but to get up 6 CCBHCs this spring, another 3 this summer, another 9 by next year, and then the remaining community mental health centers or CCBHCs get up to 26 total, which is the number of community mental health centers in Kansas by 2024. So that's the implementation is still in process. Medicaid postpartum coverage. That actually, the legislation provided funding, the budget bill provided funding to extend Medicaid coverage. So that was approved and it's been signed into law. There were a number of funding provisions that were related to recommendations. So there is about $30 million put in for regional inpatient beds, and then there was a proviso in the more recent, the second budget bill, really looking specifically at about half of those funds potentially in the South Central, kind of Sedgwick County, Wichita area for additional inpatient beds. But there's actually an interim committee that was also created to look at the need for those beds, the location, the number, et cetera. There's also funding provided for the mobile competency evaluation expansion, kind of as exploration of a pilot working with community mental health centers to expand that. There's some of them that already have done that work, but piloting it with some others to expand it. As well as some funding for behavioral health rates, reimbursement rates, and there was funding for expanding that mental health intervention team grant program as well. It went it's now about a $10.5 million program, so an addition of about, well, it was 7.5, now 10.5, so about a $3 million addition to be able to add additional schools. The 988 Suicide Prevention Lifeline, there's still some legislation. The Kansas legislature is coming back again next week. There's some standalone legislation that has gotten to a conference committee report, so it could go forward to create a sustainable and long-term funding for the lifeline and for the services. There was money put into the budget, though, if that bill doesn't pass, to at least get the funding for the upcoming fiscal year for those services, including the mobile crisis services. And then I think it's kind of interesting, it's not specifically tied to the legislation, to the work of the special committee, but an interesting outcome was that in April, there was a summit, and maybe some of you heard of it, in Topeka, and it was all three branches of government in Kansas met, and it was organized by the courts, by the judicial branch. And they had a discussion, I think the first of its kind, at least in Kansas, where they had all three branches really talking about some of the key challenges and issues. And a lot of that was following up the work of the special committee. The judge, particularly who was in charge of that, had gone to a national meeting where something similar was done. So he was already inspired to do it, but then he was also put on the special committee. So I think there are real opportunities around additional branches of government basically being engaged in, and as Dr. Minkoff said, maybe it's the third rail, or maybe everybody's aligned now, at least in understanding the problems or identifying them. Solutions, they're still in process, but there really is a lot of energy across government and policymakers, and certainly among stakeholders, for trying to move forward to solutions in behavioral health space. So I think I landed almost exactly on my time. And I know we're going to take questions later, but thank you very much for the opportunity to present. And hope it wasn't completely repetitive after Valerie's recommendation or presentations on the kind of things Kansas is really interested in as well.
It's great.
Yeah, thank you. Thank you so much, Carrie. That was wonderful. And I think hearing from both sides of the state is great. And this was an excellent presentation. So we are down to our last presentation of the forum. Just wanted to remind everyone to put any questions or comments you have for any of the speakers in the chat before our Q&A. But our next speaker is Emily Snow, who is the Director of Behavioral Health Initiatives for Blue Cross and Blue Shield of Kansas City. And she'll be providing a payer perspective on the need for initiatives to measure quality and outcomes in behavioral health. So the floor is yours, Emily.
Thank you so much for having me. It's going to be kind of hard to follow these folks that just were on, but I appreciate.
Emily,
Yeah. Oh, am I on mute?
you're not on mute, but we're getting you twice. We're getting an echo or a reverberation of your voice.
Is that a little bit better?
Not quite. Some more, a little more.
I'm so sorry. Let me turn my volume down on my computer, possibly.
That might help.
It sounds like your mic is not completely attached. It's very crackly.
Is that better?
A little better, I think.
Okay, give me 1 second. I have a different microphone.
And you know what? That was a little bit better. It's not all the way better, but a little bit better. I had microphone problems as well. That's why I didn't even use mine today.
Is this better? Is this an improvement?
Yes.
Okay.
Thank you. Okay, we're all
Thank you.
good.
That's much better. Thank you.
Okay. I've been trying out some different microphones, so please bear with me. Thank you so much for having me. My presentation is just a little bit different than everybody else's, but I hope you enjoy it as well. I am talking about the need for quality initiatives and measured outcomes in behavioral health services. We have, for many years, excuse me for a second here, we have I'm sorry, I'm having a little bit of problem with my screen. For many years, we have done measured care in medical care, but not in the field of behavioral health. So this is something that we are starting right now with payers and with other individuals. So sorry, again, slideshow problems. Give me just a second. There we go. Okay, sorry. So behavioral health and substance use, I don't think I need to tell you all about these issues. They are a leading cause of disease burden in the United States, and it's surpassing cardiovascular disease and cancer. And I think this group probably knows about the statistics. 1 in 5 adults have had a diagnosed behavioral health condition in the past year. And individuals with behavioral health conditions experience higher morbidity and poorer health outcomes, and a 20-year lower life expectancy than the general population. So that's why we want to look at how to improve the outcomes for our community and our patients when it comes to behavioral health. Behavioral health.
Emily, I believe we're one slide
I
behind
know we are.
you.
I am so sorry.
Thank you
Here
so
we go.
much.
So measurement-based care is an integral part of routine medicine. For example, patients and clinicians expect to have regular measurements of blood pressure to monitor hemoglobin, or blood pressure, or A1C to monitor diabetes. And without these measures, quality care is absolutely impossible. So why aren't we doing this in behavioral health? Providers have been kind of slow and reticent to incorporate measurement care into routine practice. To do so would mean to systematically use standard clinical tools to aid in individualized clinical decision-making regarding diagnosis, treatment, selection, side effect management, and relapse prevention. And I know my providers, they don't use measurement-based care at this point. They don't ask me, they don't do a PHQ-9 or a GAD-7, which measures anxiety. They just ask questions and take notes. So there are some relevant data elements to measurement-based care. It's typically focused on patient progress and outcomes. There is a model called the Precision Mental Health Framework, and that provides a wide range of data elements to be considered to measure and track service processes and patient outcomes. Because what's really most important here are our outcomes for our patients, because long-term, their lives will be improved, their quality of life improves, and their actual health outcomes improve as well. Precision mental health is an approach to prevention and intervention focused on the needs, preferences, and prognostic possibilities for any individual via initial assessment, ongoing monitoring, and individualized feedback. Personal data includes diagnosis and diagnostic developmental or cultural variables. Aims and risk data are collaboratively determined targets and expected outcomes of the intervention. Service preference data indicates patient choices from among appropriate interventions, and intervention data including dose and intensity, duration, fidelity, cost, and timing of services. There's progress data, which includes routine collection of information about changes in intervention targets. Mechanisms data really looks at variables that link interventions to the actual outcomes. So we are not only measuring via instruments, we're really looking at what the outcomes are. And then contextual data is monitoring and mediating variables within and external to the system. For example, what happens outside the patient's daily life and in their home and in their community. Each of these data elements provides value as a comprehensive approach to measurement-based care, but most providers and practices who do practice measurement-based care are likely to concentrate on aims and risk, progress, intervention, and mechanisms data. So there are two distinct types of assessment instruments, and these can help determine, choosing your instruments can help determine whether you are able to personalize the care, or if you want care that can be compared to the community or a similar population. Standardized instruments are designed to assess the same constructs for all patients with standardized rules for administration and scoring. In behavioral health, these instruments typically take the form of rating scales, where validated, reliable Likert-like style items are administered and translated into scale scores. The meaning of a patient's score form is a standardized instrument, and they're interpreted based on a comparison to norms in a larger sample of patients. These norms, or information about distribution of scores in the population, allow for the estimation of clinical cutoff scores to determine if a given patient is well compared to norms, and estimate how change on a measure can be considered reliable rather than measurement error. So benchmarks such as clinical cutoffs and expected recovery curves based on normal samples, they provide visual references for clinicians to use in assessing progress, and may be associated with more effective measurement-based care systems. They're pretty straightforward and simple, those types of instruments. But individualized instruments were developed to track change in the specific assessment targets for individual patients. These typically involve identifying a specific treatment target, for example, cutting as a form of self-harm, establishing a metric for monitoring that treatment target, and that would be, for example, the number of cuts in the past week, and then gathering data from the patient to monitor progress. Individual instruments can be fully tailored for a specific patient, but models also exist for conducting a more standardized fashion across patients. For example, in goal setting, in goal attainment scaling, patients and clinicians can collaboratively set a treatment goal and then monitor progress related to the goal. Like, for example, 6 days per week without cutting, and put that onto a scale rating of -2, meaning much less than expected, to 2, which would be more than expected. This approach has been associated with significant increases in goal attainment in clinical trials with clients who have serious and persistent mental illness, indicating sensitivity to change over time on goals not typically included in standard symptom-based inventories. Some of the goals that we put into these more individualized assessments are really about things like social determinants of health or positive relationships, housing, self-care, employment, or financial goals. But they're highly relevant to the client's success in treatment recovery. We know now that behavioral health we can't solve the issues of behavioral health if we don't solve some of these social determinants of health issues, because a person really can't concentrate on recovery or taking their medication if they can't purchase their medication because they don't have a job. So this tends to be much more reliable in the client's success in treatment recovery and well-being. Individualized programs have several advantages. They focus on problems that are really highly relevant to the client and the individual's actual presenting problem or goals. They're highly sensitive to detecting change. So you can see when patients are improving or sliding backwards pretty easily because of the very clear goals that have been set. They're also consistent with a personalized medicine approach, which is really where we are headed when it comes to caring for patients. We look at integrated behavioral health and how we can personally help improve patient outcomes. They emphasize individual context, the patient's goals, not the clinician's goals, and priorities. So they're therefore thought to promote engagement in treatment. They don't involve copyrighted material, so they can be very appealing to the clinician because it's not an expensive type of individualized assessment, and they're able to see improvement over time. It's important to focus, though, on how the data is used for specific purposes and outcomes, rather than focusing on what kind of measure is used. So you want to be able to use the data to improve your patient's outcomes and improve your patient's day-to-day life. So there's some challenges that we're experiencing as a payer in trying to get clinicians to implement measurement-based care. Despite the research and despite the numerous potential benefits to using measurement-based care, clinicians are often faced with the challenge of maintaining a very heavy patient load, as we talked earlier about workforce development, and that largely constrains their time. They don't feel like they have time to do these measures. Such time restrictions have been shown to deter both clinicians and leadership from employing measurement-based care, despite acknowledging their clinical value. It's actually possible that administering brief measures may streamline treatment by creating a quick method for asking questions that clinicians report they're already assessing when they're talking to their patients. So I think it's important to point out that measurement-based care most benefits the patient. That's how we see improvements. That's how we see a better life, a better quality of life. The Kennedy Forum strongly endorses the following policy. All primary care and behavioral health providers treating mental health and substance use disorders should implement a system of measurement-based care whereby validated symptoms rating scales are completed by patients and reviewed by clinicians during encounters. Measurement-based care will help providers determine whether the treatment is working and facilitate treatment adjustments, consultations, or referrals for higher intensity services when patients are not improving as expected. I can imagine that many of you are probably aware of people who suffer from either minor or major behavioral health issues that go to the same physician or the same therapist for many, many years, and their outcomes don't change. They don't become less depressed or they don't become less anxious. And so it's measurement-based care is a big benefit to that. So an indirect benefit of measurement-based care is that patient-level outcomes can be aggregated across providers, clinics, and healthcare systems to inform quality improvement activities and be reported to payers in order to demonstrate the value of the behavioral health services being delivered. So for clinicians and providers, it rapidly is becoming the standard of care. So they'll need to begin to adjust to it. A lot of digital telehealth companies have really embraced measurement-based care. But it also allows clinicians to achieve better patient outcomes faster, and they do often get paid more for using it. There are codes, billing codes for providers to use to be reimbursed for measurement-based care, and it's fulfilling to see your patient do better. And so for payers, we're motivated when it comes to measurement-based care, as we recognize the correlation between better behavioral outcomes and improved physical health. Someone with a behavioral health issue most certainly has poor physical health and higher costs to care for the physical health and the behavioral health. Measurement-based care is really about quality over quantity. We see better patient outcomes, less errors, improved patient and provider satisfaction, and lower costs all around for both the patient and the payer. And it tends to, just like I said, improve quality of life. So this is the way we're heading in behavioral health. And it's a very interesting way to do this. And I think as we integrate behavioral health with physical health, we'll continue to do more measurement-based care. Thank you for having me. I'm sorry, this is just a little bit different, and I'm sorry about my technical issues, but I appreciate you allowing me to speak about this today.
Certainly, there's no problem with the technical issues whatsoever. It happens to all of us. So thanks.
So, look, my name's John Spertus. I am really impressed with the quality of these presentations. So I just can't thank all of you enough. And I actually have a number of questions for everyone. I do hope others will weigh in, but I'm going to steal the floor while I have it. The larger question, so I'm just going to end, just as Emily gave such a great presentation, you know, the value of routine screening and monitoring of mental health, whether it's with the PHQ for depressive symptoms or the GAD-7 for anxiety, et cetera, you know, getting primary care docs or, you know, a cardiologist like me to use this, you know, it's very hard to change physician behavior. But one way to do it is to actually pay for the assessment. Just as you pay $35 for hemoglobin A1C, if you paid even $5 for a PHQ-9, I imagine it would be embedded in the infrastructure of the way we deliver care. And, you know, one of the challenges that clinicians have, especially as a cardiologist, like, what do I do if they screen positive? You know, Blue Cross Blue Shield has been a real leader in trying to address mental health of its customers by creating mindful and other strategies. You have such powerful levers with both the ability to reimburse for the collection of this, as well as something to do or a protocol to follow should someone screen positive. Is that a direction Blue KC is thinking of going? And is that something that could be done to help accelerate the use of measurement for understanding the burden of mental health conditions on patients?
Absolutely. It's very interesting as a cardiologist, and you have a lot of knowledge about Blue KC as well. And so you'll probably see where we're headed. You'll get a chance to see where we're headed in this area pretty soon. It's also interesting because we just spoke with a medical group who said that people with cardiac symptoms tend to have depression and they need help and access on where to go. And so we have connected them with our case management system in order to help provide those patients with better behavioral health care. Also, part of what we are looking at is integrated care, so that physicians who are not highly experienced in behavioral health can learn how to do those PHQ-9s and those GAD-7s and be reimbursed for them, and what to do when something comes up that looks as though it might be an emergency or a situation. And so that's part of the larger work we're doing towards value-based care and integrating care to help members get assistance. Because you might not know this, but I'm going to guess you do, John, and many of you here on this call know that 70% of behavioral health issues are first brought to their primary care physician. So we need to include primary care in this discussion for sure.
Well, great. Well, I'm very excited to see what you do. I think you could be a huge and powerful agent for change. I have another sort of broader question that really I think, Ken, Valerie, Carrie could all really address here, which is that Stacy, myself, Carol Decker, when we were first launching the High IQ QVIC initiative, we met with the C-suites of, I think, 16 different hospitals in the region. And the reason we did this is we wanted to understand their priorities. The way these collaboratives work, we don't have money to pay to implement things like a clinical trial, but the idea was that if there was something that was important to the provider, to the hospital, because we started with hospitals, and they were already investing it, by collaborating, maybe we could help them get an even greater return on their investment. And as we did this survey, I would say for every single hospital, the top 3 was mental health. And, a lot of them were saying we need more beds, we need a place to refer people. Obviously, we're not going to be able to build, psychiatric beds and do that. So we put it on the back burner. And that was part of Stacy's bias about calling it the third rail, because we just felt powerless to do it. And yet listening to the really thorough assessment that, Ken, you provided, and that report, anything you could do to encourage the Missouri Foundation for Health to release that, because we would learn a lot from it. It sounds fantastic. And the plans happening and the infrastructure available in Missouri and Kansas, do the providers know about this? Are we linking this to the health systems and the ERs, that they're sort of aware of easy sort of one-touch referrals or ways to connect with the resources that we have available? Because my assessment is no, but then again, I mean, as a cardiologist and researcher, I wouldn't really know these things. But from your perspective, do you think there's been a good communication with the health systems? And, are there ways that we could better leverage the infrastructure we already have as a prelude to building a better safety net and infrastructure for caring for patients with mental health issues? And you're all on mute, so and feel free to speak at once.
Since you're directing some of this at me, John, let me answer a couple of these things. So first of all, in terms of the report's relevance to your local region, since you're focused on Kansas City, you could talk to Health Forward and see whether they would be willing to share the report elements that are specific to Jackson County. Because the issues with their 2 foundations, and they each have their own perspective about what might be available to work with. That's the first thing. The second thing, and I really want to underscore this, as long as folks kind of feel like this is someone else's problem and we want to get a Band-Aid, like to get these people out of our ER somehow, no one's going to get where they need to go. So our recommendation is, in the same way that you look at all of the health issues you're addressing as the function of a comprehensive population health collaborative, you need to establish that same frame around behavioral health. And within that, then to target specific issues of concern. So, Valerie did a very nice job describing the department's initiatives around the crisis system. So I'll just focus on 2 things that are relevant here. One of them is, there are people in our emergency rooms in crisis. And if you're an emergency room doc, what you're thinking is, I want to get them out of my emergency room and put them in a bed. Well, that's not necessarily what they need. And it's not the best practice for designing a behavioral health crisis continuum for the community. And whatever the department is doing, I want to remind Valerie that she said the State Department of Mental Health can't fix this all by itself. So all those programs that they're doing are only a subset of all the capacity that's needed. And the best way to address that, not just in Missouri or Kansas, but everywhere across the country, is for everybody to pool their resources to develop a continuum of services that has adequate capacity for the size of the community. So one of the things we were recommending for just for the Missouri side is that there might be need for 4 crisis centers in different regions of Jackson County, because it's a population of, 500 to 700,000 people, depending on how you count. And you're not going to get there with 10 beds. There are just too many people who have need. But the hospital systems in many communities are great partners in this. And they're partners in the sense of investing in creating the continuum of crisis services and partnering with the community mental health agencies and other community partners to create an adequate continuum of service and to engage payers like Blue Cross Blue Shield in paying for the full continuum, which currently in Missouri, the commercial payers do not pay for. Okay, and Medicare does not pay for, but there's federal legislation currently that is hoping to direct Medicare to do that. But everybody needs to step forward and sit around the table and say, look, this is a problem for all of us. A related issue is the broader issue of population health. So at a very simple level, large health systems are realizing they have to move from population health based on we're selling procedures and we're in a sickness system, who we're responsible for populations, and we have to be responsible for overall wellness. And there are a variety of incentives for that, partners with payers, accountable care organizations, penalties for frequent readmissions. And what the health systems are learning is that, again, they need a systemic approach where they're partnering with the community providers to work collaboratively to identify these high-need populations and work together to figure out how to help them. One of the things I would direct you to do, because we flagged the Greater St. Louis Behavioral Health Network, they have a number of projects where the large, with their partners, the large health systems in that region, we're actually working on various elements of people who are homeless with behavioral health needs, who are frequent users of emergency rooms and various subsets of different versions of that, to actually invest in producing better outcomes and higher costs, working with those community partners under the auspice of the network, which is able to do the collaborative planning and bring data and resources together to help folks implement this in a systematic way within a quality improvement lens rather than just one-off projects.
So, there's a lot there. You also alluded to your interest in implementation, and I look forward to the details in your report, but it seems like there must be some way to implement within the healthcare systems, better referral networks to existing resources that are available in the region. And, while the payment and the support for that are certainly challenges. I mean, it's my impression that there's not, maybe the social workers have a really good finger on the pulse of how to avail themselves of this, but that in clinics and in EDs, there's not necessarily an easy way to understand how to access what services are available. And if you were to try and think about implementing a strategy in a region that is struggling to address the mental health challenges of healthcare, how would you think about starting on this road?
Okay, so again, there are two, the more that you remember where I started, okay? Behavioral health is a community issue that requires a shared framework of collaboration. And this is not something that we normally think about even in healthcare, okay? But you have to be proactive about creating it. And it becomes progressively more important to have that structured collaboration when you're looking at the populations who have the greatest number of challenges, which exist in both the public sector paid world and the private sector paid world, as I'm sure Emily knows. So the first thing to do is to say, we can create a collaborative approach to making, using a technology-based, access to referrals. And in fact, the 211 system in St. Louis under United Way has made a great effort to do that. It's really quite lovely what they've accomplished. But it's important to remember that people who can respond to being handed off to referrals and essentially be their own care coordinators are not the people who are most in need.
No,
So-
I get that. I mean, and I love the community-based strategy. The problem is somebody has to have ownership, and there has to be funding and an infrastructure to be able to develop, support, nurture, disseminate
Well,
that. And
exactly.
who's going to do that? I mean,
Well, let me start by suggesting that the large health systems in the region might step into this. And I'm sure you're familiar with the Greater Kansas City Health Collaborative that has formed and is beginning to kind of try to pull together both large health systems and funders to engage in the beginnings of this collaborative structure, which is a little higher level and at least in its concept than just the QI initiative. But if you know, and I'm, you know, in the St. Louis region, and I can't, you know, go back and forth to this because, you know, it's not like it's a perfect thing, but they created a regional health commission because they wanted that kind of formal quasi-governmental public-private partnership structure to be managing a complex region. And the Greater St. Louis Behavioral Health Network was spawned under the umbrella of the Regional Health Commission. And this is not something that pops up overnight. I'm talking about, you know, 20 some odd years worth of development in order to get to this place. And the part of our recommendations were to actually continue to strengthen the behavioral health network. And when Valerie said, we're going to use that as a partner, as a department, as a vehicle for our initiatives, that's brilliant. So thank you, Valerie, because it's a much smarter strategy from the state level than just dealing with the individual designated agencies. So, but, you know, and I don't know that much about the Kansas side, but that structure is what we were recommending get started on the Missouri side in your region, because it's not there. And, you know, if you start it, it's not going to be immediately like what they've developed in St. Louis, or even some of the levels of collaboration in places like Springfield or Columbia, but it needs to step forward. I mean, right now, there are some excellent agencies and they work sort of together, but this level of collaboration between the large health systems and the 4 CCBHOs, or 5, if you count the Clay County and so forth, that's just not structured. That's not built. And if you want that, then people have to step in and say, we want this. And that's why we were thinking that the local funders could you know, provide the seed funding that would attract people to step in. And then once folks saw that there was some value coming, others would want to contribute to that. Because otherwise you just keep going from Band-Aid to Band-Aid and you never quite get over the top of the situation.
I think that's really great and wise. I think, you know, it would be very valuable to sort of reconvene some of the speakers and do some, you know, thinking about this. But as we are coming up on time, I just wanted to know if, you know, Carrie or Valerie or, you know, anybody else had any sort of final words that they wanted to sort of inform the group with.
No, I did throw some stuff in the chat. Thank you, John. We are, I mean, always aware, always got to meet people where they're at when they're there, right? And that includes all different clinicians. So, you know, we constantly have a request for more acute beds. We know that inpatient beds are not always the answer. We want to try to, again, serve people in the least restrictive setting. The other challenge with inpatient beds is actually getting those stays funded for enough time that it is meaningful. But there's lots of other ways to deliver services. So we really, a key part of what you're saying here revolves around technology and getting recovery support providers and mental health services providers and hospitals and all of those groups of people together. But also we're working on a bed registry. So what can we do to get the information people need quickly out there? And then how do we grow with all the information that people need to truly be effective operators? So there's a lot of the information we need out there. It's just not integrated together.
Valerie, that's really good. And I was going to piggyback on what Dr. Minkoff was talking about as well. So, and I threw some of this in the chat too, but, you know, I really appreciated what you said about saying this isn't the problem to solve by getting people out of the hospital, unless they're inappropriately in the hospital. They could be getting services elsewhere. I think a lot of the issues and the barriers for access to behavioral health goes back to just how behavioral health is treated, like it's a whole separate system, like it's a whole separate, it's not really part, there's population health and there's physical health and medical care, and then there's behavioral health. And I think we've got different payers, different regulatory systems, everything that sort of reinforces that idea that it's distinct and separate. And so it's kind of maybe their job and not our job or whatever. And integrated care, really truly integrated care, not just in the community setting, but, inpatient at every level. I think that that's the direction that is both promising, but so hard because those systems are still there. So I think something that would be interesting too, to follow up a conversation on is what are the system barriers that, partners can help identify to say, why aren't they doing that? Why, when you go to talk to the C-suite folks, Dr. Spertus, so they, that's the issue, but hey, we can't find a place to send somebody instead of, hey, this is the healthcare for our patient base. So how would we approach it if it was another health issue that they were dealing with? Is try to have the same framework. So I think that Dr. Minkoff, what you're talking about, sort of a real collaborative approach that cuts across and recognizes the silos that are still there, but also tries to just knock them down, because that's, I think, the only way to get there. There's whole new, completely different systems. You'll have, the hospitals in Kansas, they're part of the special committee, the hospital association. They've got members in the hospital. But it's still true that in a lot of places throughout the state, a lot of the work that's being done isn't necessarily communicated to among different provider types. And folks that are like, they should be part of the conversation, they don't even know the conversation is going on sometimes. So I think that's a real opportunity statewide, certainly in the Kansas City area, to be able to engage folks and not just having here's our behavioral health discussion, but this is a part of our overall. So I really appreciate you convening this too, because this isn't some separate issue. It's health.
I couldn't agree more. In fact, that's a great note to end on. And I don't mean to cut you off, Valerie, somebody else had something else they wanted to say, but I really can't thank, this was really stimulating. I really enjoyed it. We're going to think a lot more about, we're trying to define a next project to engage on. And obviously there's an enormous need for this. And you've given us confidence that there may be a path to help get the community together to handle this in a multi-stakeholder fashion. So thank you so very much for your time. And we really appreciate it. And thank you all for joining.